Good afternoon. You're hale and hearty folk. My name is Betty Shiels, and I am with the University of Louisville, Kent School of Social Work, and I'm the director of the Kentucky Emergency Preparedness for Aging and Long-Term Care program. And we have been working in emergency preparedness under contract with the Kentucky Department for Public Health, with both hospital preparedness money from ASPR as well as FEP money from the CDC. And I've been working in the field approximately 14 years. And when I was hired being told it was a one-year grant, and who knew what would happen afterwards, because we were going to do terrorism and seniors. And that was enough of a hook to grab me to say, yes, I'd be interested in doing the job. And 14 years later, and I can't tell you how many presidential declarations of disaster we've been through in those 14 years, here we are again. In my work with aging and long-term care, our program has worked with all of the community-based agencies serving seniors over the years. And approximately 10 years ago, the Department for Public Health came to us and said, we have not had any luck working with long-term care. We've even offered them $100,000 and had to turn back $77,000 because they are a unique group of people in a unique industry, and it is hard to engage them. And as a result of that wonderful contract 10 years ago, we developed the Kentucky Emergency Preparedness for Long-Term Care manual. And it has been identified as the best practice by ASPR in long-term care preparedness. That manual has provided the foundation work for many of our long-term care in Kentucky and their emergency preparedness. As a result of that work and our interest in aging, I was then asked to co-chair the Kentucky Functional and Access Needs Collaborative as part of the Kentucky Department for Public Health Preparedness Branch. One of our initial efforts was to undertake a needs assessment of the HUD-funded affordable housing preparedness for seniors, and what were the issues and access needs and gaps for that population. Because as most of you know, in terms of vulnerable populations, once we get past children and the elderly, we get into almost single-digit population representation. Those two populations, 0 to 18 and over 65, are the two largest populations for vulnerable populations. My colleague, Becky Gillis, is the director of the Division for Public Health Protection and Safety with the Kentucky Department for Public Health. And Becky will introduce herself. She's going to share some comments and some fascinating lessons learned during the presentation. Our Functional and Access Needs Collaborative is made up of a wide range of representative groups, from advocacy groups such as the Office for the Blind, the Office of Deaf and Hard of Hearing. We work with psychological first aid through the Kentucky Community Crisis and Response Board. We also work with the Department for Aging and Independent Living in the collaborative community-based services, workforce development at the Cabinet for Health and Family Services, as well as Kentucky Emergency Management and the volunteer organizations active in disasters. So you can hear the range of representation that are members of the collaborative. And over the years, we have focused on a wide range of activities, but this afternoon, I'm going to focus on the HUD-funded housing population for seniors and 202 and 811 programs. There are significant challenges in Kentucky, as in every state, in terms of first responder issues, preparedness issues, planning issues, as well as shelter operations. Kentucky is among the top 10 states in the country, historically, for the last 15 years, in the number of presidential declaration of disasters. Who would have thought this state in the middle of the country that's bordered on three sides by the Ohio River, that is built on limestone, which makes us, I think, the second highest risk state after Florida for sinkholes. In eastern Kentucky, we have the deep coal mines, and with so many mines left and retired over the years, we have a high risk for subsidence. We're also in Tornado Alley, and along with the Ohio River floods, we also have all of the tributaries and creeks and smaller rivers that feed off of and into the Ohio River. Kentucky is also one of the 8 states most at risk for a major earthquake at the New Madrid Fault. So not only do we deal with tornadoes and floods and sinkholes. If any of you remember when there was a sinkhole that opened right in the middle of the Corvette Museum in Bowling Green, and they lost, I believe, 8 cars, 8 historic Corvettes. We deal with just about everything, and we used to say except for hurricanes. And in 2009, with Hurricane Ike, that storm came right up through the middle of the country from the Gulf and took out power across Kentucky for over 2 weeks. So we've had our fair share of experience with hurricanes as well. Kentucky ranks 10th in the percent of population. We have a lot of top 10s, unfortunately. We rank 10th in the percent of populations of those 65 to 74 years old. For Kentuckians over 65, our poverty rate is 11.2 versus 9.5 for the country as a whole. There are 3 metropolitan urban areas in the state, and the rest of the state is very rural. From strip mines to deep coal mines, from the mountains in the east, the Appalachians, to the foothills of the Smokies leading into Tennessee. Kentucky is ranked 3rd in elder poverty in the country and 2nd in adults with disabilities. So why do we care about older persons with functional and access needs? I think it speaks for itself. This is a table of the disability rates for persons over 65 in Kentucky, including our rankings. I can't get away from these rankings. If you look at the table, you see that we rank 2nd in the country with the worst degree of mobility for persons over 65. We rank 2nd in those with cognitive impairment, 2nd in those with cognitive and mental issues, 3rd with those for physical impairment. So ADLs for persons over 65, especially for lower income persons and those living in isolation in rural areas, again supports our concern for this group. After Hurricane Sandy hit New York, a sample of older persons 65 to 80 was surveyed, and the numbers were quite impressive. Over a quarter of them knew of programs or organizations that actually prepared for disasters. They knew where to get information. They knew how to get information. Almost half did admit that they would have difficulty evacuating and getting down from their place of residence to an evacuation site. 40+% knew about a community center, but another study, which I didn't cite here, found that well over 60% of those surveyed said even if they knew it, and even if they knew about plans, they would never evacuate. And I know Becky's heard this story from me many times. We had, everything is historic in weather these days. We had a historic ice storm, and it affected the whole western half of the state. I live in Louisville, Kentucky. That's the largest population center in the state. In the Louisville metropolitan area, emergency medical services received 13 calls from family members who were concerned about their elder who lived alone and who probably had lost power and did not know what the situation was with food and water. So emergency medical services went out to those 13 residences, and not one of those people was willing to be evacuated. No matter what the conditions were in their homes, they were going to stay. And one thing we can say about Kentuckians is we like being self-sufficient. We have those deep Scotch-Irish roots, and we like being self-sufficient. During the hurricane, or during the tornado in 2013 that affected the middle part of the state and southern Indiana, it took out part of an entire town. The county it impacted lost 65% of their housing stock in one afternoon, an entire county's housing stock. When shelters were opened the next day, and we had a conference call with the ESFA partners, what we found was across the counties that had been impacted, nobody was coming to the shelters. They chose to sleep in their cars on their property, and temperatures at night fell below freezing. And during the day, we had a heat wave during the day, and we had these very cold nights. During the day, the temperatures were in the high 80s, low 90s. So we had people with hypothermia. We had people with severe sunburn. The range of needs were amazing for that same event in that same area, that same region of the state. Kentuckians don't leave. So community resilience is a hallmark of our culture, and individual resilience is a hallmark. But how do we get them working together is the issue for our target population. During Hurricane Sandy, there was another bit of research that was done with New Jersey seniors, and they found that the most trusted sources for communication about emergency preparedness was radio, TV, and government sources. There was zero response for the internet. There was a very low response for social, what is it? Media, thank you. It's clear I'm not a user. It's hard enough to keep up with emails and texts. HUD-funded tenants are the least likely to use smartphones and to have access to smartphones and the internet. So in communicating with that population, just to warn them in terms of preparedness so they can be resilient, it is best to use the trusted sources of radio and TV and having an official spokesman from the jurisdictional powers, if you will. One of the big impacts affecting this population is Medicaid and community-based services with Medicaid waivers. How many of you are aware of Medicaid waivers for the elderly? Just a few. During the last 10 years or so, the federal government has been moving away from supporting people in nursing homes. And the focus has been to keep people who live in the community independent living in the community. So Medicaid waivers 1115 for the elderly were started to provide community-based support services using in-home visitation. So the goal is to keep people living in their apartments, in their houses, for as long as possible, because the cost of nursing home care continues to be relatively high. So we now have a population that would have been eligible for nursing homes in the old days, and now is living many times in isolation in the community. So for those of you in the room who are interested in the whole concept of resilience at the community level, one of the hidden populations out there that may be the hardest to reach would be isolated seniors, unless they're fortunate enough in a way to live in HUD-funded affordable housing, where at least they're co-located in a building. Why do we care about affordable elder housing in terms of preparedness? This target population is not engaged in healthcare coalitions. They're not an organized group of people. These are individual tenants living in apartments owned by property owners who received loans from HUD. So HUD is not operating services, if you will, at these locations. These are people living independently in apartments. One of the major concerns and lessons learned comes from the number of multifamily, multi-story buildings where many of this population live, especially in urban areas. We have a property in downtown Louisville that has 3 buildings that are probably 22 stories tall. One building is for seniors only. One building is for seniors and the disabled, and then another building is for other low-income housing. 20 plus stories of people living in isolation, if you will. And if there's a power outage, what happens? With older persons or persons with disabilities, if you live on the 20th floor, especially if your power goes out and it's dark and the elevators aren't working. You can imagine. So there are ambulation barriers with many of these tenants. There are bariatric barriers. One of the most fascinating pieces of information is that this is the population in 202 and 811 housing that has the longest tenure in any HUD housing. They live in these properties longer than any other HUD-funded population. The goal for affordable housing technically has been to get people housed so they can get stabilized, they can establish employment, and they can move out. This is the population that doesn't move out, and many don't move out until death. So they are ambulatory when they move in, they age in place, they become more impacted in their activities of daily living and mobility issues, they have cognitive issues, they have other health issues, because the average person over 65 has 5 to 8 chronic health issues, if you think about it. I have bad hearing in this ear, I wear glasses, I have arthritis in my knee and in my foot, I have other health issues, and I'm functional. Think of the ones who aren't functional and have been living in high-rise buildings in isolation for 10, 12 years And they may be ambulatory when they walk in, and over years they've become disabled and or bariatric. And those are not issues that the site managers concern themselves with because they're managing rental property. So if we don't worry about them, nobody worries about them. This population is also unidentified by emergency managers and first responders. It's fascinating. There'll be a fire across the state in a single story or 1 to 4 level affordable housing unit, and the tenants will be evacuated to a parking lot, and the fire chief lets the county emergency manager know. The county emergency manager emails state emergency management. State emergency management emails ESF8, Health Department, Becky's unit, and then they email me because I work with long-term care, and invariably the report from the fire chief and all the way up the line is a long-term care facility was evacuated. A long-term care facility was evacuated because it has older people in the building. We're not used to differentiating between independent living older people and persons living in long-term care. Persons living with long-term care in long-term care have more supports than this population has in an emergency and especially during an evacuation. This population would evacuate to a Red Cross community shelter and therefore could bring a significant potential burden on that shelter because many of them are not eligible for a medical shelter, and under current guidelines they would be put in a general shelter, a general population shelter. HUD-funded housing for older persons can run the gamut of moderate to very, very low income. $10,000 to $12,000 would not be unusual for income for somebody living in a 202 unit. We're also talking about frail and very frail tenants because with the Medicaid waiver, we're trying to keep them out of the nursing home. It's interesting when I've talked to first responders about aging and long-term care in this population, they think of long-term care populations actually what we now call assisted living populations because the acuity is so high of those living in long-term care. This population is not quite eligible for long-term care, but they certainly aren't eligible for assisted living. And yet their supports come as a result of their Medicaid waiver services. HUD emergency preparedness requirements are building-based, not tenant-based. When I first started working on my needs assessment with this group, with the HUD-funded group, what I found, I went to HUD, I read all their regulations on the 202 and 811 properties, and nowhere in there does it talk about tenants, except that if they have to exit the building, or let's say, we might call it evacuate, they have 30 days to let the HUD people and their property owners know that they're coming back to their building. The guidelines from HUD speak to what do you do with the infrastructure of the building? What do you do with the walls? What do you do with the wiring? How do you get the building back in shape? Not how do you get the people in shape? So there was this glaring gap when we were doing our needs assessment. And then also, families and communities are looked to assist tenants in their needs. And yet I have given presentations to HUD property manager audiences of hundreds of people in an audience, and I'll say, when do you see the family? How might you engage a family? And they raise their hand and say the family, by and large, doesn't come around until after the person has died and they're divvying up what's left with their personal effects. So we operate in a fantasy about this population, and we are ill-prepared to respond to their needs. This is just a listing, a table of Kentucky HUD-funded properties for elders. You see that in Kentucky there are 2,600 202 funded units. And that can be for single people, for married people, or you could end up having a two-bedroom household where they have, let's say, a disabled adult child who may live with them as well. Then the 811 funded population is significantly less than that with 511 units, and I'll talk about the differences in my next slide between 202 and 811. And then we have 42 locations and 3,000 plus tenants in low to moderate income. That would be Section 8 or other housing authority housing. 202 is primarily the HUD-funded housing for elders. Very low-income elders to live independently in an environment that provides support services. Now, the environment itself may not be the provider of the services. They may support use of the Medicaid waiver to bring in InHome Visitation. There are some HUD-funded properties under 202 housing that are part of a campus of what's called a CCRC. And a CCRC is basically a campus with a continuum of care of retirement services from total independent living with patio homes to 202 units to personal care, maybe some assisted living thrown in there, and then ultimately up to skilled nursing. They offer the full range of continuum of care. Because CCRCs will now come under the final rule for emergency preparedness for nursing homes as well as assisted living, many there'll be application of many of those planning efforts also for their 202 properties. So in terms of who's prepared the most, it's the CCRCs. That is a very small number compared to the total 202 population. 811 housing is not only for elderly, but also for other persons falling under a disability category, including intellectual and developmental disability. And you may have mental health issues in there, as well as some substance abuse issues. As I said earlier, this is the longest residency of any HUD-funded program, and they leave either to death or some actually are able to go to long-term care prior to death. This is a table of the dispersion in Kentucky, across Kentucky, of our 202 and 811 buildings. And what you bottom are the numbers for our area development districts, which are a proxy for our hospital preparedness program regions. And there are 2 regions where there are no HUD-funded 202 and 811 housing. But what's striking, who can guess which region is Louisville? Sticks out like a sore thumb. And then to the far right is the Lexington-Frankfort region. And then to the far left is Region 1. Region 1 is the most western region in the state and southwestern region in the state, which is primarily rural, The largest city in that entire region is Paducah. If any of you have heard of Paducah, Kentucky, or the Quilt Museum, that's probably what Paducah is most known for. It's got the best quilt museum in the country. And it's worth a stop, as I'll say, if you have an interest in quilts. Prior to going into social work, I did the unthinkable. I worked in finance for 20 plus years. And I retired from finance and made the decision to worry about other than people's fear and greed. So what did I do? I went into social work and into emergency preparedness work. And greed isn't a piece of it, except for there's never enough funding for us. But the fear piece is always there in preparedness. What's interesting about Region 1 is the company I worked for in the investment business back in the 70s and early 80s jumped on the HUD bandwagon and offered limited partnerships for tax deferrals and created and funded a whole lot of low-income housing in Region 1. We had an office manager in Region 1 that put almost everybody into these limited partnerships. So lo and behold, we have this funny little region with the third largest number of units in the state. How many in the room have had interactions during a disaster or have had a concern about persons living in HUD-funded properties, especially among the elderly? A few of you, go. It's fascinating the rest of you are here. Who'd like to share why you're here if you've not had this concern up until now? Sir?
I'm in Santa Rosa County, Florida, which is lower Alabama in the state, because Florida ends when you go west of Tallahassee. And Santa Rosa County has a rather large elderly population. The thing about it is, it's like Kentucky. It's spread out everywhere. We have that's our big thing. We have a huge landmass, and it's just the elderly folks are spread out anywhere. And being a planner, that's something I'm interested in.
The response, we're actually being taped, so I'm going to feed back the response, was the gentleman is from West Florida, correct. Southwest Florida, Northwest Florida. And they're much like Kentucky in a wide dispersion of seniors living sporadically over a large landmass, and obviously has a concern. Why is anybody else interested today? CEs, I guess. Okay. We have another hand.
I am a director, actually, and I'm interested just to see how we can work with programs to prepare for this. There's such a growing number of older adults coming into our county, and as well, the abilities of those adults are so diverse in terms of the active lifestyles versus individuals who are in care facilities. And so how do we adapt our programs and work with our partners to be able to prepare for that entire spectrum?
We have a very forward-thinking organization that has an increasing population of seniors with a diverse range of abilities, and wants to begin to incorporate programs and activities and partnerships to serve this growth area, this growth population. We have another person.
I'm a unit coordinator for a Medical Reserve Corps unit, excuse me, who has expressed interest in working with our senior populations. Many of them are seniors that volunteer, and they recognize the need, so we're looking at different ways that we can impact that population.
Wonderful. We have somebody from the Medical Reserve Corps, the MRC, who's interested in this population and finding ways to work to serve the population as well. There are so many ways of coming at this, and there's no right way or wrong way. We all need to come at it. just to share some of the differences that we find between urban and rural locations. The greatest volume of our locations are urban. The urban ones, as I've said, tend to be multi-story, significant multi-story buildings. Rural tend to be 1 to 4 stories. The numbers in a 1-story property can be very low in rural areas. Nevertheless, they are an unidentified group. As I said, they're viewed as nursing home residents, and nobody quite knows what to do with them. And the smaller ones tend to be in small rural counties that have the least amount of resources to respond to the county's needs, much less this population. Here's a Kentucky case study of somebody you might find living in a 202 building. Lucy had a stroke, and which has left her with residual left hemiparesis. She experiences weakness and difficulty with balance, but is able to ambulate with the assistance of a walker. Because of weakness in her left arm and hand, Lucy can feed herself and prepare simple meals with a microwave. She requires assistance to prepare hot meals, other than in a microwave. Lucy can shower using a shower chair, but needs assistance getting in and out of the shower and washing her hair. She can dress herself, but needs assistance with buttons and zippers and putting on her shoes. Lucy's on medication for hypertension and diabetes. She experiences short-term memory loss and requires assistance in remembering to take her medications. Lucy receives multiple in-home visitation services. There's not a front desk in one of these buildings, like you might imagine, that has sign-ins of all the in-home visitation visitors. So site managers don't know the range of services that a tenant like Lucy might receive in a week or in a month. From housekeeping to caregiving to OT to PT, I mean, the range of services that those who are lucky enough to have Medicaid waivers is extensive. Some people get 11 visits from different services a month. It's not unusual. Now, the problem with the Medicaid waivers is, in Kentucky at least, it's a 4-year wait list. And I imagine it's similar in other states. And with issues with the federal budget, who knows where we're going. One of the things that we don't think about is these in-home visitation services are a resource in a disaster because they are contracted to provide services. If Lucy ends up in a shelter and nobody knows she has access to these services, the shelter manager might start getting phone calls from some of these agencies to find out if Lucy's there, if there's been an evacuation of that building. Some of them are even willing to come and deliver services at the shelter. But there's not a way yet to find a list and recognition of the range of services that might be available. Because you can imagine in a community shelter, and I've run this by the Red Cross, and it turns out they don't keep or have the records available, but I just said an informal survey, how many of those in your years of experience with Red Cross shelters are over 65? And the answer I get is over half. So this is the preponderance of persons that we see in Red Cross shelters in a bad situation. So for those of you that are thinking about outside the box, how do we work with other partners? How do we tap resources out there? Because there aren't enough, obviously, or it wouldn't be called an emergency. and the money keeps getting less and less, so we have fewer and fewer people on our payrolls to help, so we really need our partners. Sheltering elders in emergency shelters may need assistance with ambulation, with dressing, with toileting, with medications, with oxygen management. Many have sight and hearing impairment. One of the issues with sight and hearing impairment, if you want to work with these buildings, the 202 and 811 buildings, is you have well over half of persons living there have sight and hearing issues. So if first responders are going up and down a hall yelling out, it's time to evacuate, it's time to go down the stairs, we've got stair chairs to get you down. If they're hearing impaired and they've run out of money to get the hearing aid batteries, they may not hear somebody going up and down the hallways. Same if you're going to try and hand them a brochure or information if they have vision issues. So we need to be creative in the way that we can communicate and respond with this population. Assistive devices get lost in evacuations. We learned that with Hurricane Katrina. People died because they didn't have their glasses and they couldn't see the signs to go to the bathroom. They couldn't see the signs for help. They developed wounds, skin tears, and developed infection, and some of them died because the glasses and the hearing aids and the walkers didn't go with them to the shelters. The critical partners for responding and for working in an emergency response continues to be local and district health departments, county emergency managers, departments for aging and independent living, because they work with the area agencies on aging, and those are key folks working with Medicaid waivers and other in-home services, community-based services across the board, community mental health centers, and the American Red Cross. Becky's going to share some lessons learned related to working with the mental health and substance abuse population who are eligible for this housing.
Do this one slide from there. Okay. So as Betty had said, we had asked her to do this needs assessment because we continue to get those calls from the emergency management saying that it had been a nursing home that had been evacuated, and so many times, when we looked into it, we would always find out that it was a HUD-funded. It was a HUD facility, and so we asked Betty. I said, can you do a needs assessment? Help me understand who is living in these places across the state, so that we can do some better planning. So I applaud Betty and her work that she has done on this needs assessment, because it helps guide us in our emergency planning. But she'd asked me today to talk about one event that happened back in 2008. I've been in preparedness sort of from the beginning. Since 2002, I was a program coordinator, and that became one of my programs that I've coordinated. So I worked out of a couple of local health departments, and been the preparedness director for the state since 2009. So I've been through a number of responses in my years here. So in 2008, we sheltered about 1,500 people that came from, I think it was the Louisiana area, in Kentucky for about 9 days. And so what we had some events where we had some large shelters open in our state because of the ice storms, and I've had some personal experience with doing that and working in a local health department. But FEMA had told us that this is going to be a healthy population. You won't have any health and medical needs at that time, and we knew better, having had some big shelters open in our state previously. So I just wanted to describe to you a little bit about some of the issues that we saw there. We quickly determined there was going to be a need for law enforcement around the clock in this large shelter area. as we did the triage and the incoming of the people, we did begin to separate some people out. About 50 of the 1,500, approximately 1,500 people, got put into a medical needs shelter, separated from the general population for whatever reason. You know, Lucy, as our example here, might have been a good example of somebody who might have gone into that medical needs shelter. And I'm not a clinician, so I can't answer a lot of questions related to that. But my job during that time period was to try to find public health workers who could go in and staff that medical needs shelter. Because even though Louisville is our largest health department, they were having trouble staffing that around the clock for 9 days. That was a long-term event for us. So my job was to help staff that medical needs shelter. What we did was set up clinic. We had a clinic that was open. I think it was open from 12 to 2 each day with healthcare providers there. We had nursing support there around the clock, and then a number of people doing general, running and support of that. We had a need for behavioral health counselors, and we have a volunteer network that's similar to the Medical Reserve Corps that's composed of people with social work or counseling type backgrounds. And so we were able to call on those, but we also found that we had to call in some psychiatrists because we found some psychiatric illness that required higher level of care than what these counselors were needing, could deal with. We had to set up a child care area. We had supervision issues, so they set up a child care area there to help with that. But one of our biggest issues that we faced were the number of prescription medications that were needed, and especially the number of people who were drug seeking, coming to say, I left my prescription of this narcotic. I wasn't able to bring that with me, so I need those prescription narcotics. And so that became a major issue for our clinicians and for our pharmacy for a variety of reasons. So I'm going to talk a little bit later on about some of our lessons learned related to that. We now have a mobile pharmacy in place where we have a secure place for our pharmacists to work and to keep those medications. So I'll talk a little bit about that later on. But
Thanks, Becky. Hurricane Sandy and Hurricane Matthew both included and involved significant impacts to affordable housing units and locations. In Manhattan, there were buildings that were 35 stories tall, no power, no water, with Hurricane Sandy, obviously. Food soured in the refrigerators of people because they couldn't get down, they couldn't see. You can imagine the anxiety that those tenants were experiencing. High-rise apartments. What happened was the American Red Cross responders, including one of the regional leads who happens to be in Louisville and had a major role in that experience, worked with the emergency managers. And what they found was if they could get the needs and the resources to the street, responders were willing to carry the resources up the floors of the apartment buildings. So volunteer organizations offered food, there were water supplies coming in, there were those headbands with the lights, like LL Bean lights, so that people would be able to get around their floors. There was a tremendous benefit by keeping, imagine how many units and how many people were living in that building, to keeping them sheltering in place for their sake, as well as for the pressures and the demands that were already created for general shelters. So I think one of the most important lessons with that is to think outside the box, and with any older person, evacuations are potentially dangerous. There are unintended negative outcomes frequently in evacuating older persons, especially frail elders. And so they found that if they could keep them sheltered in place and get the resources to them, firemen and other first responders were willing to get the materials up to them. Blankets, pillows, linens, whatever was needed. Depends, probably would have been on that list for that population. What they didn't consider was the need to organize everybody trying to help. And what happened was, when they would have their shelter at the curb, they called it, things were going well. It tended to be during daylight hours. People who were living in the building could see that help was coming. They could see the responders on the floor. They could see the resources coming up the steps, as well as receiving them in their apartments. But then other nonprofit organizations started to be generous and would bring resources when it was convenient for them, but they didn't consider that the doors would lock at 8 o'clock and there's not a site manager who lives on the premises. And so the tenants didn't know they were coming with the material, and there weren't responders to carry it up the floors. So a lot of those good efforts went to spoilage, went to frustration on the part of the nonprofits, as well as the tenants, who sometimes could see the people leaving because they couldn't get in. So part of this is about considering our stereotypes about where elders live, and not every place is assisted living or a nursing home. And not every place has a door person or somebody sitting at the front desk 24/7. So in the work in the future with this, what some of the folks, responders working in Hurricane Matthew, found was a much tighter organization of that effort, much tighter communication of that effort, and a better response. These are the issues I just talked about. So as a result of all this, after the needs assessment, Becky took me aside one day and said, let's work with your nursing home emergency preparedness manual, the Kentucky Long-Term Care Emergency Preparedness Manual, and would you be willing to create a similar manual for HUD property managers? So I put together a group of folks who were subject matter experts, I certainly wasn't, on what it would take and what were the key elements that would be needed in such a manual. The members of the committee include the regional Kentucky HUD manager, somebody from the Kentucky Housing Corporation, our program, the Kentucky Emergency Preparedness for Aging and Long-Term Care, Leading Age Kentucky, which is one of our 2 state long-term care associations, and they support the CCRCs, many of which have 202 housing. Leading Age at the national level has expertise, and they've also offered to assist us. American Red Cross is part of that team and is going to review the final, or the next to final draft of the manual and give us input on that. Obviously, the Kentucky Department for Public Health Preparedness Branch, I combined two units there, I apologize, as well as the Department for Aging and Independent Living, the Kentucky Community Crisis and Response Board, which is our psychological first aid organization, and the Department for Public Health. So we got these folks together, and instead of starting from square one, I said, let's take a look at the table of contents of our long-term care manual. And you tell me what we ought to keep and what topics that we don't need. So the group started going over the topics, and as we did, we were clearly also dealing with gaps in preparedness for HUD in their 202 and 811 housing. The frustration, again, for HUD during that group was the acknowledgement that the property owners are landlords, they're investors. They don't operate programs. They oftentimes are corporations that may own 10 to 50 of these units all over the southeastern part of the United States. So it's not just a local owner. You've got owners all over the country that then have site managers. And site managers tend to cover 3 to 5 locations per week. So they're driving the circuit, if you will, like the circuit riders, visiting the properties 2 and 3 times a week for a half a day or a third of a day. The only person who's on site the most for most of a day is, of course, environmental. And who knows tenants? It's just like in nursing homes. If you want to prepare somebody and to get a facility prepared, who knows the most in a nursing home about emergency preparedness and what you need to know? It's maintenance and environmental, because they know how to turn the gas off. They know how everything works, and they know everybody. Well, that's the same thing with environmental in these HUD buildings. The tenants all call them to fix their plumbing, to help with electrical. So they are basically the trusted resource in a building, more so than a site manager. The challenge there is they have no power or authority. Guidance for emergencies focus on the structure. So if you work with HUD and your regional HUD folks, it's important to also know what their concerns are about structure and response for the structure. It's about mutual concerns. The decision to evacuate, we found out, may only be made by property owners. Site managers don't have the authority to call for an evacuation of a building. Site managers have to call the property owners, let's hope they get them, and the property owners approve the evacuation. And then site managers do not have to have a plan for physical evacuation. I was in a room of HUD managers a number of years ago, and there were probably 400 managers in the room, and I said, how many of you have emergency plans? 10 people raised their hands. I said, how many of you have an evacuation plan for your tenants? 1 person out of 400. And the jaws dropped for the others because they had never thought about it. So we identified gaps in HUD preparedness as individual, not only do locations not have preparedness plans, but individual tenants don't have to have a preparedness plan. Their families don't have to have a preparedness plan. There's no listing of family contacts in an emergency plan that might be held on site in a file for the tenant. There's not a procedure to identify the in-home visitation services that may actually be one of your best resources. And there's no formal mechanism to check on tenant safety during a disaster because they're landlords. They don't operate a program. And then you have the whole issue of HIPAA, because many of these folks do have health issues, and their hands have been tied until we've gotten guidance now on a site manager, even an environmental manager, being able to share any information with anybody, even family members if it's not signed. We had no idea what the flow of communication was between property owners, site managers, environmental, and HUD. And that's HUD at the regional level, much less HUD at the national level. So in working with the HUD regional manager who had just gotten back from serving in the Hurricane Matthew response, we gathered this information. I created a flow chart. A disaster event occurs. The HUD regional manager tends to be the one who calls the property owner. unless the site manager found out about the disaster and happened to call them first. But oftentimes, the HUD manager is the one to call a property owner. Because think about it, if you're a site manager, this happened in West Liberty, Kentucky during the tornado. That site manager was 3 counties away at another property. And she was driving back to West Liberty and heard about the tornado on the radio. So she had no idea what she was going to face 2 hours later when she got to West Liberty. So you have the event. In all likelihood, the HUD manager will be the one to call the property manager, or you hope that the site manager also knows. Property owner, then the site manager or environmental are the ones who could call your county emergency manager. The tenants haven't got the capacity in many cases to call the EM. So think about it. If you've got 100 units in a building and there's an event and nobody knows who to call, well, hopefully somebody might call 911, which in Louisville is the same thing as calling your emergency manager. If there is an evacuation, it's generally to a Red Cross shelter. And even though there's no formal policy within HUD, the HUD managers tend to go to the shelters and check on the tenants if they know that the tenants are in shelters. And they'll do that weekly because they have responsibility for at least providing housing for up to 30 days. If the person isn't able to come back to the building or isn't able to leave a shelter for 30 days, then on the 31st day, it becomes a FEMA issue. And FEMA becomes responsible for finding housing for these folks. And there are statutes about all this. So one of the things, if you're interested in creating programs, don't leave FEMA out and don't leave HUD out of this. Because there are already processes in place to expedite this. Now, what the Red Cross has taken to doing with vulnerable populations in some of the disasters is putting them up at hotels to keep them out of the general shelters. And what the man who had just come back from Hurricane Matthew service said is, it's well over the 30 days. FEMA has found some units for them or some trailers for them, and guess what? They don't want to leave the hotel. But that becomes a FEMA issue. So you don't have to volunteer to get in the middle of all that, is the message I'm trying to offer. It's important to get the key players and the key partners at the table so that everybody's informed. And I have to say, this regional HUD manager is so excited about this manual. He wrote a mini manual for HUD managers out of his Hurricane Matthew experience. It's about 12 pages long. That's all. Because that's how narrow that focus is. Our manual, I know, is going to be probably 100 pages. It'll be electronic, it'll be online at our website. He's so excited he wants to present it with me to the major national HUD managers group. I don't know how well that'll go over. So I want to run through the content areas that we are focusing on in our manual. The basic plan elements. How to create a plan. I mean, we're talking about people who don't know how to create a preparedness plan. You could be paralyzed just at that thought, because where do you start? Especially if you don't have staff. I mean, there isn't any depth in these endeavors. Just thinking about what your top 3 hazards are, the beginning of a hazard vulnerability analysis. What are your most common hazards? Is it flood? Is it flash flood, or is it Ohio River flood? Is it a tornado? Is it a severe thunderstorm? Because our severe thunderstorms, I don't know about yours, can be as bad as a tornado many times. We also have in there incorporated a record of the distribution. Who did you share this information with? And we ask them to put the name, the date, and the contact information, and to update that on a regular basis. We have a section on how to develop relationships, because site managers don't think about emergency management. They're not always aware that that's your most critical partner in a disaster. So we've incorporated that material. And then how to coordinate with your local emergency responders. Then we have a section on operations planning. And again, that's a challenge because that plan is one person deep. Because environmental has the most knowledge, but environmental has no power. Site managers are dealing with 3 and 5, sometimes 10 properties. Organizational chart. We included it even though there are so few people because we thought it was important that somewhere it was written down who was in charge and who had authority. Also, we've included templates to capture resident and tenant needs, a profile for each of them, as well as the list of services provided to each of the residents or tenants, those in-home visitors. And then we have templates for individual and family emergency preparedness plans. And we are creating templates and tools for managers, site managers, to annually or biannually hold preparedness meetings in the lobby with the tenants. So that everybody starts talking about it, everybody starts hearing about it, and maybe begin to fill out part of that preparedness plan. Then we have guidance and some templates on hazard vulnerability analyses. We also have templates that we incorporated from our long-term care manual that covers 20 different types of hazards. And it tells you what are the first things to turn off. Is it the gas line? Is it water? Et cetera, et cetera, et cetera. What are the basic needs? What do you do if the elevator's out? Communication planning. We included this because there isn't any communication. And we thought, well, if we include it, they might think about it. They might talk about it. They might realize that it would be really helpful to have this written down. Also, means to contact families. Maybe think about having some policies or some procedures about contacting families in an emergency. And then emergency contacts lists. Response planning. Sheltering in place. What are adequate supplies? What is adequate water to have on hand, even for 3 days, if you're a location that has 100 people living in the building? Also, medications, hydration needs, and dietary needs. All of that obviously is part and parcel of a good individual emergency preparedness plan. In an evacuation, who has the authority to call for evacuation? I would think legally it would be very helpful to have a piece of paper that provided guidance for the property manager to know what the parameters are about evacuation, and then who's allowed to request assistance from the emergency manager. And then there are the employees. You know, we don't think about the employees. Again, in one of the presentations I gave to a room full of HUD managers was after the tornado in West Liberty. And one of the managers raised her hand and started talking about that day and what it was like when the tornado leveled the town and leveled all that housing stock. And she said the tenants could hear the people screaming in the buildings next door as the buildings were being demolished. That the psychological first aid issues were front and center because of the questions these people had, the ability to figure it all out and to sort out what they were spared. And employees need that same support. as well as psychological first aid for employees, and a family disaster plan for employees. We find with long-term care, if your family is taken care of, if your staff and you know your family is taken care of because there's a plan, and you have a family plan and you know exactly what they're going to do, staff tend to show up for work. Or if they're there at the time of the disaster, they tend to stay and work through it because they know what's going on at home. Mental health planning. So the solutions that came out of this whole experience, as well on top of the manual, included the recognition that this is first and foremost a housing issue, and to consider that first. The best option is for them to shelter in place, planning, and to incorporate in that plan first responders, the American Red Cross, public health, and healthcare coalitions. The need for a list of family contacts, identify medical issues, in-home service providers, who accompanies the tenant to the shelter. How does a tenant even get to a shelter? And then have emergency plans as part of the move-in process. It turns out tenants in HUD 202 and 811 units have to reapply for recertification every year. So we're suggesting that when they reapply for certification every year, that they also update their emergency plan. And they update their health conditions and their contact information. And then to provide a copy of the emergency plans to the site manager or environmental, however the organization is set up. And one of the operators in our group had this light bulb go on over his head and said, you know, my insurance agent would really be interested if I had this plan. And I wouldn't be surprised if it lowered some of my insurance rates. He said that's probably the best reason to have one of these plans. And that's great. Whatever it takes to get it on people's radar. We're suggesting that buildings begin a floor block watch group where there's a director on each floor who checks on people during a disaster. And then that person can communicate down a floor, and it just continues down so that the site manager or the environmental manager have some sense of what's going on the floor, especially if power's out. We suggest annual tenant training on emergency preparedness, develop relationships with nearby churches that may volunteer to check on tenants in a disaster, train housing staff in working with persons with dementia, because you're going to have a high percentage of your tenants with dementia. And then one of our goals is to disseminate this manual to the property owners of locations in Kentucky, as well as HUD regional managers and national managers. Our manual will be available in the next 30 days. It'll be posted up on our website, the Kentucky Emergency Preparedness for Long-Term Care.com, KYEPLTC.com. And on that same website, we just put out our updated Kentucky Long-Term Care Emergency Preparedness Manual that has taken all of the elements of the CMS final rule for nursing homes and identified through a crosswalk where those are all covered in that manual. And if it's a CCRC, because they'll have the manual for long-term care, we're hoping that they will also apply that to their HUD properties. Now Becky's going to talk about the lessons learned with the mobile pharmacy.
Anybody come today because they're interested in hearing more about the substance abuse kinds of concerns? Okay, so I'm going to talk a little bit about that in the next few minutes here. I'd said that one of the issues that we faced with that large shelter situation was the pharmacy issues and the substance abuse issues. So one of our lessons learned was we needed a space for our pharmacists to work in a real pharmacy program. So the next year we purchased this mobile pharmacy unit here in Kentucky. And what we did was we built a program out of that. This mobile pharmacy is actually licensed by the Kentucky Board of Pharmacy and also by the DEA. We have an agreement with the Kentucky Pharmacists Association where we've built a network of volunteers from across the state who can be called upon to come volunteer and work in this. And we have an agreement with a wholesale distributor so that we can get almost like a push package. If you're familiar with the SNS program, the push package, we can get the 200 most commonly prescribed pharmaceuticals, drugs pushed to us within 6 to 8 hours anywhere in the state and get that delivered to this mobile pharmacy. We have security plans in place for the mobile pharmacy and all that. We have protocols, of course, in place to use that. So I'm going to switch gears a little bit and just talk a little bit about, we've had this asset since 2009. We haven't actually utilized it except for exercises in Kentucky yet. We almost utilized it once in a flooding event because the only pharmacy in a small community had been affected by the flooding event. So we were rolling this mobile pharmacy. We got word that the bridge going to the pharmacy area was no longer accessible. So we turned around and had to bring it back. So we almost used it, but what happened, and this is a little bit maybe off the topic, and I think it's so interesting I wanted to share with you. We have this asset, right, in Kentucky. What happened was this past year, in August of 2016, we had a surge of overdoses in Kentucky. And what happened was the public health commissioner said, this is a public health emergency. So I'm going to call on my preparedness folks to come and help us with this. He said, I want you guys, and this was a quick turnaround. He said, this is going on today. And we think with the Labor Day weekend coming up, this is likely to be a major public health concern for us because we suspected there was, heroin with fentanyl and carfentanil out there that was causing all these overdoses. So he said, I want you to build a communication strategy. So we built on all the partnerships that we had in place to be able to communicate with especially our healthcare providers across the state, that we thought this, and the public, that we thought that this was, a real possibility with the holiday weekend coming up, that we may see even more overdoses in our state. He said, I want you to develop a surveillance strategy. So again, use those same partners to come up with a surveillance strategy so we have some better real-time information about the number of overdoses that were occurring across the state. And we did that by working with our hospitals. We actually had them report directly to this. And for now, going forward, this has now been turned over to the Poison Control Center, or taking those reports from hospitals. But we came up with that quickly. So come up with a response strategy. So several partners, we came together, and these are some of the things that we've been doing since that time. We've been using this mobile pharmacy asset to go out into the communities and distribute Narcan. You guys know what Narcan is. So we partner with the local health department. They do the advertising. We partner with the Kentucky Pharmacists Association. We roll this mobile pharmacy into the community and distribute Narcan in that community. We provide education in our state. Anyway, Narcan is actually available without a prescription, and we have hundreds of pharmacists across the state who have this ability now. They have to go through some training to be able to do this. But we offer this education. You don't have to have a prescription going forward. And we're continuing to build some better real-time surveillance and alerting capabilities using our preparedness network to be able to alert when we see these kinds of events occurring. So just recently, our state, anyway, in Kentucky, we did our state health improvement plan, and so substance abuse was one of our top 5 priorities for our department to work on in our state. So this is a true public health emergency event. So I just wanted to share a little bit about those lessons learned and how it's progressed to sort of where we are today.
Thanks, Becky.
Yeah.
Obviously, we don't waste any lessons learned. And I doubt if anybody here wastes a lesson learned either. So we can open it up for Q&A. Anybody have any questions of either one of us?
Question for Becky. Do you use your medical reserve corps in this type of outreach with an arcane training?
Some of those volunteers that we are using volunteer pharmacists from across the state, so some of them are involved with the Medical Reserve Corps, but the Pharmacists Association actually has a separate program that's sort of under the umbrella of